The human body is constantly exposed to a wide array of microorganisms and environmental threats that challenge its ability to maintain homeostasis. To counteract these threats, the immune system has developed a complex network of defense mechanisms, beginning with innate immunity, the body's first line of defense against pathogens. Unlike adaptive immunity, which requires prior exposure to develop specificity and memory, innate immunity is immediate, nonspecific, and operates as a rapid response system designed to detect and eliminate invaders before they cause harm. Innate immunity consists of physical barriers such as the skin and mucous membranes, which prevent the entry of pathogens, as well as cellular and molecular components that recognize and respond to infections. Key players include phagocytic cells such as macrophages and neutrophils, which engulf and destroy microbes, and natural killer cells, which target virus-infected or cancerous cells. Additionally, the complement system, a series of plasma proteins, enhances pathogen destruction through opsonization and inflammation. A critical aspect of innate immunity is its reliance on pattern recognition receptors, such as toll-like receptors, which identify conserved molecular patterns associated with pathogens. Upon recognition, these receptors trigger signaling cascades that lead to the activation of inflammatory responses, cytokine protection, and recruitment of immune cells to the site of infection. Although innate immunity lacks the specificity and memory of the adaptive immune system, it plays a pivotal role in shaping subsequent immune responses and bridging the gap between early defense and long-term immunity. With innate immunity, there are three overarching components that make up innate immunity, which are physical barriers. This is the skin and mucous membranes, chemical barriers. These are the antimicrobial peptides and enzymes, and then cellular defenses. And these are the phagocytic cells like neutrophils and macrophages. In the first line of defense, physical and biochemical barriers and the human microbiome, um, innate barriers form the first line of defense at the body surfaces. These barriers can be physical, mechanical, and biochemical. Surface barriers also house a group of beneficial microorganisms known as the normal microbiome that protect us from pathogenic microorganisms. And then second line of defense is inflammation. And this is a protective response that supports recovery from injury and disease. The inflammatory process is activated by virtually any injury or vascularized tissue issue. Triggers include infection and tissue damage, and this is things such as ischemia, trauma, chemical injury, foreign bodies, and immune reactions. So comparing innate immunity with adaptive immunity, looking at level of defense, your first line of defense against infection and tissue injury for innate immunity is constant. The inflammatory response is an immediate response. And for adaptive immunity, this is a delay between first exposure to antigen and maximal response, immediately against secondary responses to same antigen. And then looking at specificity, for innate immunity, it's broadly specific. The inflammatory response is nonspecific, whereas with adaptive immunity, the response is very specific toward a target. Looking at the cellular level, for immediate immunity, epithelial cells are involved, and then in the inflammatory process, mast cells, granulocytes such as neutrophils, eosinophils, basophils, monocytes, macrophages, natural killer cells, platelets, and endothelial cells are involved. And then with adaptive immunity, it's T lymphocytes and B lymphocytes, macrophages, and dendritic cells are involved. Memory for innate immunity, there's no memory involved with innate. Also, when the inflammatory process, there's no memory involved. With adaptive immunity, specific immunological memory by T and B cell lymphocytes are formed. And then with innate immunity, active molecules are defensins, collectins, lactoferrins, and bacterial toxins. With the inflammatory response, there's activation of complement, clotting factors, kinins, and cytokinins. And with the adaptive immunity, antibodies and complement and cytokines are involved. And then protective uh, level for innate immunity is a protection includes anatomic barriers such as the skin and mucous membranes, cells and secretory molecules such as lysozymes, your pH level of the stomach and urine, and ciliary activity. With inflammatory response, protection includes vascular responses, cellular components such as mast cells, neutrophils, and macrophages, secretory molecules or cytokines, and activation of plasma protein systems. And with adaptive immunity, protection includes activated T and B lymphocytes, cytokines, and antibodies. There are five cardinal signs that your patient will present with and that you should look for that would indicate an inflammatory process is happening. The first is pain, the second is heat, third is redness or erythema, the fourth is swelling, and the fifth is loss of function. There's two stages to inflammation. In the acute phase, this is the body's immediate and early response to injury, infection, and harmful stimuli. This is characterized by rapid onset, short duration, and classic signs such as what we just reviewed: redness, heat, swelling, pain, and loss of function. Response is immediate by immune cells such as neutrophils and involves the release of chemical mediators like histamines, prostaglandins, and cytokines. The primary goal of acute inflammation is to eliminate pathogens, clear necrotic cells, and initiate tissue repair. In chronic inflammation, that's in this stage, this is characterized by prolonged inflammatory response that can last weeks, months, or even years. It occurs when the acute response fails to eliminate the causative agent or when there is continuous exposure to harmful stimuli, such as persistent infections, autoimmune diseases, and chronic irritants. And this can include, this primarily involves macrophages, lymphocytes, and fibroblasts. This is associated with tissue destruction, fibrosis, and angiogenesis, which can contribute to conditions like atherosclerosis, rheumatoid arthritis, and chronic lung disease. It also plays a role in many diseases, including cancer and metabolic disorders. With the inflammatory response, the vascular response is vasodilation and increased capillary permeability. This allows for immune cells and proteins to reach the injured site. And then there's the cellular response. This is where white blood cells, especially neutrophils and macrophages, migrate to the site to neutralize pathogens and remove damaged tissues. And then there are chemical mediators such as cytokines, histamines, prostaglandins, and leukotrienes that coordinate the inflammatory process. And then finally, you come to the resolution or repair time of the inflammatory response. And this is when the inflammatory response concludes with tissue repair, resolution, and progression to chronic inflammation if the stimulus persists. Protection at the body's surfaces is a critical component of the body's first line of defense in the immune system. This protection consists of physical, mechanical, and biochemical barriers that prevent pathogen entry and maintain homeostasis. Key aspects of protection at body surfaces: with physical barriers, the skin acts as a tough, waterproof barrier preventing microbial invasion. The mucous membranes line the respiratory, gastrointestinal, and genitourinary tracts, trapping and expelling pathogens. With mechanical barriers, tight junctions between epithelial cells prevent the penetration of microorganisms. Cilia in the respiratory tract move mucus and trap debris upward to be expelled. Tears, urine, and saliva flush out potential pathogens. And then with biochemical barriers, sebum and sweat on the skin contain antimicrobial peptides. Lysosomes in the tears, saliva, and mucus break down bacterial cell walls. And within the stomach, your pH level destroys ingested pathogens. And then there's normal microbiota, and this is on your skin and within your system. These outcompete harmful microbes that help to maintain a balance. These barriers function non-specifically and are crucial in preventing infections before the activation of innate and adaptive immune responses. Physical barriers offer considerable protection from tissue damage and infection. These barriers are comprised of tightly associated epithelial cells of the skin and of the lining of the GI, genital urinary, and respiratory tracts. When pathogens attempt to penetrate such barriers, they may be removed by mechanical means. For example, microorganisms may be sloughed off with dead skin cells, which are then replaced. Epithelial cells of the upper respiratory tract can trap microorganisms through the production of mucus and remove them through the action of hair-like cilia, which move the mucus upward where it is expelled through coughing or sneezing. Invading microorganisms can be removed from the GI tract through vomiting or defecation, and from the urinary tract through urination. Other protective mechanisms of innate barriers include the relatively low temperature present on the skin and the low pH found in the stomach and the vagina, both of which inhibit the growth of pathogenic microorganisms. Inflammation affects many parts of the body. In the brain, pro-inflammatory cytokines cause autoimmune reactions in the brain, which can lead to depression, autism, poor memory, Alzheimer's disease, and multiple sclerosis. In the cardiovascular system, inflammation in the heart and arterial and venous walls contribute to heart disease, strokes, high blood sugar, which leads to diabetes and anemia. In the muscles, inflammatory cytokines can cause muscle pain and weakness. They can manifest as carpal tunnel syndrome and polymyalgia rheumatica, to name just a few of those processes. In the bones, this interferes with the body's natural ability to repair bone mass, increasing the number of fractures and leading to conditions like osteoporosis. In the skin, chronic inflammation comprises the liver and kidneys, resulting in rashes, dermatitis, eczema, acne, psoriasis, wrinkles, and fine lines. In the thyroid, autoimmunity as a result of inflammation can reduce total thyroid receptor count and disrupts thyroid hormone function. In the lung, it induces autoimmune reactions against the linings of the airway, which can result in allergies or asthma. In the GI tract, the damages our intestinal lining and can result in issues like GERD, Crohn's disease, and celiac disease. With the kidneys, cytokines restrict blood flow to the kidneys. Complications like edema, hypertension, nephritis, and kidney failure can result. And with the liver, buildup of inflammation leads to an enlarged liver or fatty liver disease, and this increases toxic load and buildup in our bodies. Key features of the inflammatory response are with the vascular response, vasodilation and increased capillary permeability allow immune cells and proteins to reach the injury site. In cellular response, white blood cells, especially neutrophils and macrophages, migrate to the site to neutralize pathogens and remove damaged tissue. Chemical mediators such as cytokines, histamines, prostaglandins, and leukotrienes coordinate the inflammatory process. And then the inflammatory response concludes with tissue repair, resolution, or progression to chronic inflammation if the stimulus continues to persist. In the acute inflammatory response, this occurs in two stages. The first stage, the vascular response, again, this is where vasodilation increases blood flow and increased vascular permeability allows exudate to form. And then the second stage is cellular response. So this is where leukocyte migration happens to the injury site and phagocytosis of pathogens and debris occur. In the resolution of acute inflammation phase, if the cause of inflammation is eliminated, anti-inflammatory signals promote healing and tissue repair. If the stimulus persists, acute inflammation may progress to chronic inflammation, which can lead to tissue damage and fibrosis. In the acute inflammatory process, chemical mediators that are involved are histamines, which cause dilation and increased vascular permeability, cytokines. These are proteins like interleukins and tumor necrosis factors that modulate immune responses, and prostaglandins, which intensify inflammation and pain. The process follows a series of steps leading to vascular and cellular responses, which help in eliminating pathogens, repairing tissue damage, and restoring homeostasis. In the first step, tissue and cell injury and pathogen invasion, injury or infection triggers the body's immune response. And the mast cell degranulation and synthesis release histamines, prostaglandins, leukotrienes, chemotactic factors, and growth factors. These chemicals mediate inflammation by affecting blood vessels and immune cells. And then activation of plasma proteins includes complement proteins, clotting factors, and kinins, which help in immune defense, clot formation, and inflammation control. And then macrophage activation, a release of tumor necrosis factor alpha, interleukins, and interferons are released to recruit and activate other immune cells. And then in the vascular response, this leads to vasodilation, which increases blood flow, causing redness, which is called erythema, and warmth, increased capillary permeability. This allows immune cells and proteins to enter tissues, leading to swelling. This is called edema. Thrombosis, this is clot formation to prevent excessive bleeding. And then cellular responses lead to cellular infiltration and phagocytosis. These are immune cells such as neutrophils that engulf pathogens and debris, this forms pus. Stimulation of nerve endings, this results in pain, alerting the body to injury. The acute inflammatory response is essential for eliminating infections, clearing damaged cells, and initiating tissue repair. However, excessive or chronic inflammation can contribute to disease processes. Plasma protein system is a critical part of the body's innate immune response and plays a key role in inflammation, immunity, and homeostasis. These systems are activated in response to tissue injury or pathogen invasion, working together to eliminate the threat, repair tissue damage, and restore normal function. The plasma protein system plays a crucial role in the body's inflammatory response, consisting of three interconnected systems: the complement system, the clotting system, and the kinase system. These systems work together to eliminate pathogens, control bleeding, and regulate inflammation. The complement system enhances the immune response through opsonization, which coats pathogens for easier phagocytosis, cell lysis via the membrane attack complex, and chemotaxis, which attracts immune cells to the site of infection. Additionally, complement proteins stimulate mast cell degranulation, releasing histamine to promote inflammation. The clotting system prevents excessive bleeding by forming fibrin clots, which also helps trap pathogens and prevent their spread. Platelet activation releases pro-inflammatory mediators, linking coagulation to the immune response. The Hegman factor, or factor 12, further connects clotting to the kinase system. The kinase system, primarily through bradykinin, amplifies inflammation by causing vasodilation, increasing capillary permeability, and stimulating pain receptors. It also interacts with prostaglandins to sustain the inflammatory process. Together, these systems ensure a coordinated immune response, promoting healing and pathogen elimination. However, dysregulation can contribute to conditions such as chronic inflammation, clotting disorders, and sepsis, highlighting the importance of balance in immune responses. In the plasma protein system, vasodilation, this is where blood vessels, particularly arterioles, widen to increase blood flow to the affected area. This results in redness and heat. Increased vascular permeability allows endothelial cells lining the blood vessels to become more permeable. This allows plasma proteins and fluids to move into the surrounding tissue. This leads to what is called swelling or edema. And then endothelial activation. This is where endothelial cells express adhesion molecules, facilitating the attachment and migration of leukocytes, these are white blood cells, from the bloodstream into the inflamed tissue. Cellular response is a critical phase of inflammation aimed at eliminating pathogens, removing damaged cells, and initiating tissue repair. It begins when tissue injury or pathogen invasion triggers immune cells, primarily macrophages and mast cells, to release cytokines such as tumor necrosis factor alpha, interleukins, and interferons. These molecules act as chemical signals that attract neutrophils, monocytes, and lymphocytes to the site of injury. Neutrophils, the first responders, perform phagocytosis by engulfing and destroying pathogens and cellular debris. Macrophages and dendritic cells further amplify the response by presenting antigens to adaptive immune cells. These are T and B cells, ensuring long-term immunity. As immune cells accumulate, pus formation or cellular infiltration occurs, consisting of dead neutrophils, bacteria, and debris. This process is tightly regulated to prevent excessive damage to healthy tissue. The cellular response also involves thrombosis or clot formation to prevent the spread of infection and stimulation of nerve endings, which causes pain as a protective mechanism. Ultimately, the cellular response transitions into tissue repair and resolution, where anti-inflammatory signals promote healing. However, excessive or prolonged activation can lead to chronic inflammation. This contributes to diseases like arthritis and autoimmune disorders. Cellular receptors that sit on the cell surface play a critical role in immune response by recognizing pathogens, damaged cells, and inflammatory signals. These receptors help initiate, regulate, and resolve inflammation. They recognize threats such as pathogens, damaged cells by activating the immune response, and this is cytokine release and phagocytosis. They help regulate inflammation by preventing excessive damage and facilitate healing and tissue repair. These receptors ensure a coordinated immune response against infections and injuries. These cell receptors lie deep within the body's defense network, a group of watchful sentinels that stand guard, constantly scanning for signs of danger. These are pattern recognition receptors, or PRRs, and they are specialized proteins that detect molecular signatures of invading pathogens and cellular damage. Without them, the immune system would be blind to threats, unable to mount a proper defense. PRRs are trained to recognize two major types of danger signals: PAMPs, which are pathogen-associated molecular patterns, and these are unique molecule structures found on microbes, bacteria, viruses, and fungi that signal an invasion. And then DAMPs, these are damage-associated molecular patterns, and these are distress signals released by injured or dying cells warning of internal damage. Once activated, PRRs set off a chain reaction, summoning immune cells, triggering inflammation, and preparing the body for battle. Each type of PRR plays a unique role in detecting and responding to threats. Toll-like receptors, these are the first responders. They sit like sentinels on the surface of immune cells. These are your macrophages and dendritic cells, and within the endosomes. They recognize bacterial cell walls, viral RNA, fungal components, and even some other dams. When triggered, they activate immune pathways, releasing cytokines to immobilize the body's defense forces. Node-like receptors, these are the cellular detectives, if you will, operate deep inside the cells. They detect hidden bacterial invaders that have breached the cell membrane. They initiate inflammation by activating inflammasomes, and a molecular machine that triggers cytokine release. Rig-like receptors, these are virus hunters. There are specialized PRRs in detecting viral RNA and an unmistakable sign of a viral infection. Once activated, they trigger interferon production. This sets off the body's antiviral response to shut down viral replication. Beyond direct pathogen detection, PRRs also work alongside other immune mechanisms. Complement receptors, these are these enhancers. These receptors recognize complement proteins such as C3b and C5a that tag microbes for destruction. They're found on macrophages, neutrophils, and dendritic cells, and they amplify phagocytosis and promote immune activation. Scavenger receptors, these are the receptors that we call the cleanup crew. These receptors specialize in detecting and removing dead cells, oxidized lipids, and cellular debris. Without them, cellular waste could accumulate, leading to chronic inflammation and disease. And the cytokine receptors, these are the communicator receptors. They listen for immune messages in the form of TNF alpha, interleukins, and interferons. They regulate inflammation, immune cell activation, and coordination. Antigen presenting receptors, these are activators of adaptive immunity. The major histocompatibility complex, or MHC-1 and the MHC-2, acts as the bridge between innate and adaptive immunity. MHC proteins display antigens to T cells, teaching them how to recognize and eliminate specific threats. PPRs form the foundation of immune surveillance, working together to detect, respond, and communicate threats. Whether by recognizing bacteria, viruses, damaged cells, or immune signals, they ensure the immune system reacts swiftly and appropriately. Without them, the body would be defenseless, unable to differentiate between friend or foe. Key inflammatory cells within the inflammatory response are neutrophils. These are the first responders. These are phagocytic cells that ingest pathogens. And then there are macrophages, which are derived from monocytes, and they phagocyte pathogens and release cytokines. And then mast cells that release histamine that contribute to vasodilation and increase permeability. Neutrophils are a type of white blood cell that play a crucial role in the immune system. They are the first responders to infection, rushing to the site of injury or infection to engulf and destroy invading pathogens like bacteria and fungi. Think of them as the body's rapid response team, always on the lookout for trouble and ready to spring into action to keep you healthy. These white blood cells are the first responders to infection, rushing to the site of injury or invasion to engulf and destroy harmful pathogens like bacteria and fungi, and they're always on high alert. When an infection occurs, neutrophils are quickly summoned to the affected area through a process called chemotaxis. They move towards the source of infection, guided by chemical signals released by damaged tissues and other immune cells. Once they arrive, neutrophils use a variety of mechanisms to neutralize the threat. They can engulf and digest pathogens through a process known as phagocytosis, release antimicrobial substances to kill invaders, and even form extracellular traps to ensnare and destroy microbes. Neutrophils are short-lived but highly effective, typically surviving only a few hours to a few days. Despite their brief lifespan, they play a crucial role in the body's defense against infection. Without neutrophils, our ability to fight off infection would be severely compromised, making them an essential component of our immune system's arsenal. Battle begins the moment tissue injury or infection occurs. A foreign invader breaches the body's defenses, setting off a chain reaction. And deep within the bloodstream, neutrophils, the first responders of the immune system, receive the call to action. These small but mighty powerful white blood cells part of the body's innate immune system, are always on high alert, patrolling the circulation for signs of trouble. As inflammatory signals like tumor necrosis factor alpha, interleukins, and chemokines flood the system, the neutrophils sense the distress and immediately respond. They leave the bloodstream, squeezing through blood vessel walls in a process called diapedesis. This journey is guided by chemotaxis, a mechanism that directs them towards the site of infection or damage. Once they arrive, neutrophils waste no time. Their primary mission is to destroy and to clear the area of infection. They quickly engulf bacteria, damaged cells, and debris through phagocytosis, trapping these intruders inside specialized vesicles. Within these vesicles, deadly enzymes and reactive oxygen species are unleashed, effectively killing the pathogen. As they fight, they release powerful antimicrobial peptides and neutrophil extracellular traps, sticky webs of DNA and proteins that ensnare and neutralize pathogens. However, their aggressive tactics come at a cost. After a short-lived but intense battle, neutrophils self-destruct, their remnants forming the thick yellow fluid known as pus, a graveyard of dead immune cells and pathogens. Through their lives, though their lives are brief, their sacrifice is crucial. By eliminating harmful invaders and signaling for reinforcement, neutrophils pave the way for macrophages and other immune cells to complete the healing process. Once the danger is neutralized, anti-inflammatory signals begin the process of resolution, ensuring that the immune response does not spiral out of control. Macrophages are key immune cells in the innate immune system that play a crucial role in inflammation, pathogen elimination, and tissue repair. They're derived from circulating monocytes and are produced in bone marrow and where they enter circulation. Macrophages are specialized white blood cells that patrol the tissues, constantly scanning for signs of trouble. The moment infection or tissue damage is detected, macrophages leap into action, setting off a cascade of immune responses. At the site of injury, macrophages release pro-inflammatory cytokines like tumor necrosis factor alpha, interleukins, and interferons. These chemical messengers spread through the surrounding tissues and bloodstream, sending urgent distress signals to recruit additional immune cells. Neutrophils, monocytes, and lymphocytes respond, migrating towards the battlefield, guided by the chemical trail left by macrophages. Meanwhile, macrophages themselves engage the invaders directly using phagocytosis. They engulf pathogens, damaged cells, and debris, breaking them down with powerful enzymes. This process not only eliminates the threat, but also presents pieces of the enemy, antigens, to other immune cells, such as T lymphocytes, helping to launch a more targeted immune attack. As inflammation progresses, macrophages shift their role from fighter to healers. They begin releasing anti-inflammatory cytokines, dampening the immune response to prevent excessive damage. They also stimulate fibroblasts, which lay down new tissue, helping to rebuild what was lost. If everything goes as planned, the inflammation subsides and the injured area is restored. But if immune response is prolonged or dysregulated, macrophages may contribute to chronic inflammation, leading to tissue scarring or even autoimmune disorders. Through every stage of the cellular response, macrophages serve as both the initiators and regulators of immune defense. They signal reinforcements and ensure that healing follows destruction. When the body detects injury or infection, a complex network of signaling molecules, chemokines and cytokines, orchestrate the immune response. These messengers immobilize immune cells, regulate inflammation, and control tissue healing. At the heart of this response is tumor necrosis factor alpha. a powerful cytokine that acts as an alarm. Released primarily by macrophages, tumor necrosis factor alpha initiates inflammation, increases blood vessel permeability, and recruits immune cells to the site of damage. While essential for fighting infection, excessive tumor necrosis factor alpha can contribute to chronic inflammation and autoimmune diseases. Alongside tumor necrosis factor alpha, interleukins function as immune system coordinators. Some interleukins, like interleukin 1 and interleukin 6, amplify inflammation by stimulating fever and activating white blood cells. Others, such as interleukin 10, work to calm the immune response, ensuring that inflammation doesn't spiral out of control. Meanwhile, interferons serve as the body's early warning system against viruses. These proteins, particularly IFN alpha and IFN beta, signal neighboring cells to heighten their defenses, slowing viral replication and activating immune fighters like natural killer cells. To maintain balance, the body also produces anti-inflammatory cytokines. These are the brakes of the immune system. These are molecules like interleukin 10 and transforming growth factor beta. They suppress excessive inflammation, prevent tissue damage, and promote healing. This intricate communication network ensures that inflammation is swift and effective when needed, but also controlled to prevent unnecessary harm. When balanced, these signals protect the body. When dysregulated, they contribute to chronic diseases, autoimmunity, or uncontrolled infections. Dendritic cells are immune cells named for their branch shape, though they are not related to neurons. They originate from bone marrow and lymph tissue and play a crucial role in immune responses. Their ability to be cultured in laboratories, along with their potent antigen-presenting properties, make them a promising tool in cancer immunotherapy. Dendritic cells function within the immune system. They are phagocytes and antigen-presenting or accessory cells. These are messengers or activators in our innate and adaptive immune mechanisms. Dendritic cells are formed from precursor cells in the bone marrow and lymph tissues and are one of three types of antigen-presenting cells. Dendritic cells, alongside macrophages and B cells, the other antigen-presenting cells. Without these cells, T lymphocytes would not recognize or react to potentially harmful invaders. They are essential for both innate and adaptive immunity, identifying antigens based on molecular patterns and triggering immune responses. Without antigen-presenting cells, T lymphocytes would not react to potentially damaging particles that enter and are produced inside the body. Found all over the body, dendritic cells concentrate in areas that contribute to immediate immune responses. These are the lung, gut, blood, and lymphoid tissues. These tissues must withstand continuous antigen attacks. So dendritic cells first appear as immature cells in these tissues and organs. Only after they have captured an antigen do they mature. Only once they have caught an antigen are they called antigen-presenting cells. As APCs, mature dendritic cells migrate to lymph nodes and present their captured antigens to lymphocytes there. Dendritic cells have an important function in the innate immune system where they carry out surveillance duties, looking for antigens in the form of endogenous toxin and exogenous foreign substances. The presence of an antigen or surface protein stimulates an immune response. This is because certain patterns of molecules on the antigen or on damaged cell membranes make them recognizable. Mast cells are immune cells involved in inflammation and allergic responses. They're located in connective tissues, especially near blood vessels, skin, the respiratory tract, and mucosal surfaces. They're activated by PAMPs and DAMPs binding with PRRs. Mast cells are strategically positioned in connective tissues near blood vessels and beneath epithelial surfaces. These cells, though small, wield immense power in orchestrating the inflammatory response. As soon as tissue damage is detected, mast cells degranulate, releasing a cascade of chemical mediators such as histamine, prostaglandins, and leukotrienes, and cytokines. The moment histamine is released, blood vessels dilate, allowing a rush of immune cells to the affected area. This vasodilation causes the characteristic redness and warmth of inflammation. Simultaneously, histamine increases capillary permeability, enabling plasma proteins in white blood cells to move from the bloodstream into the tissue, leading to swelling. This is known as edema. Beyond histamine, mast cells also secrete prostaglandins and leukotrienes, which intensify the inflammatory response by amplifying pain signals and sustaining vascular changes. These molecules ensure that immune cells, such as neutrophils and macrophages, are drawn to the site of injury. The arrival of these phagocytic cells marks a critical phase. Pathogens are engulfed, damaged cells are cleared, and tissue repair begins. However, mast cells do not act alone. They communicate with other immune cells, particularly T cells and macrophages, by releasing cytokines like tumor necrosing factor alpha and interleukins. These signals help to modulate inflammation, either escalating it to combat an active threat or resolving it once the danger is past. As the immune response unfolds, mast cells continue their watch, ensuring that the body's defenses remain engaged but not excessive. If inflammation becomes prolonged, their persistent activation can contribute to chronic inflammation, allergies, and even autoimmune disorders. Conversely, in acute inflammation, their timely intervention allows for rapid pathogen clearance and efficient healing. Thus, mast cells stand at the crossroad of immunity, balancing defense, repair, and regulation in the complexity of the cellular response. Histamines play a crucial role in the body's immune response by acting as a chemical messenger that triggers inflammation when the body detects injury or foreign invaders. They are primarily stored in mast cells and basophils, ready to be released during an immune reaction. Once released, histamines bind to specific receptors on cells, leading to a variety of physiological effects. When histamines interact with histamine 1 receptors, they cause vasodilation, increasing blood flow to the affected area, which results in redness and warmth. They also make blood vessels more permeable, allowing immune cells to move into tissues, leading to swelling. Additionally, histamines stimulate nerve endings, producing itching and pain, commonly seen in allergic reactions and in the respiratory system. This can cause bronchoconstriction, leading to symptoms such as wheezing and difficulty breathing in conditions like asthma and anaphylaxis. To counteract these effects of histamines, the body or medical intervention can introduce antihistamines, which are drugs designed to block histamine receptors. H1 antihistamines, such as diphenhydramine or loratadine, are commonly used to treat allergies, reducing symptoms like runny noses, itching, and swelling. They work by preventing histamine from binding to receptors, thus stopping the inflammatory cascade. Some first-generation H1 antihistamines also cross the blood-brain barrier, causing sedation, while second-generation antihistamines are non-drowsy because they do not significantly affect the brain. There are also histamine 2 antihistamines which target H2 receptors in the stomach. These medications, such as ranitidine and famotidine, help reduce stomach acid production and are often used to treat conditions like acid reflux and peptic ulcers. Mast cells release lipid-derived vasoactive substances that play a crucial role in inflammation and immune responses. These substances are derived from membrane phospholipids and contribute to vascular changes, immune cell recruitment, and pain signaling. Prostaglandins, derived from arachidonic acid, via the cyclooxygenase pathway, functions by increasing blood flow to the site of injury through vasodilation, enhances pain reception by sensitizing nerve endings, and regulates fever and other inflammatory processes. Leukotrienes are produced through the lipooxygenase pathway. Their function is to increase capillary permeability, leading to edema, attract immune cells, this is chemotaxis, especially neutrophils and eosinophils, and bronchoconstriction, which plays a role in asthma and allergic reactions. And then platelet activating factors derived from phospholipid and promotes inflammatory cell activation, stimulates platelet aggregation, aiding in clot formation, increases vascular permeability, enhancing immune cell migration, and induces smooth muscle contraction, contributing to bronchospasm and allergic reactions. These lipid mediators coordinate the vascular and cellular responses in inflammation, contributing to swelling, pain, redness, and immune cell activation. The process of phagocytosis is characterized by three interrelated steps: adherence in diapedesis, tissue invasion by chemotaxis, and phagocytosis. Tissue damage, adherence, margination, and diapetesis. The primary phagocyte in the blood is the neutrophil, which usually moves freely within the vessels. At sites of inflammation, neutrophils and endothelial cells respond to inflammatory cytokines by expressing adhesion molecules, which causes neutrophils to progressively develop, increasing adherence to the endothelium, leading to accumulation along the vessel walls. At sites of endothelial cell reaction, other adhesion molecules such as PCAMs allow the neutrophil to move through the vessel wall by means of diapedesis. Chemotaxis, this is when the neutrophil detects chemotactic factors gradients through surface receptors, migrates toward higher concentrations of the factors, and with high concentration of chemotactic factors at the site of inflammation, this immobilizes the neutrophil. Further specific receptors are expressed on the surface of phagocytes that facilitate recognition and attachment to ligands found on the surface of target invaders such as bacteria. And then with phagocytosis, antibodies and complement serve to opsonize. Chronic inflammation is a prolonged inflammatory response that can last weeks, months, or even years. It occurs when acute response fails to eliminate the causative agent or when there is continuous exposure to harmful stimuli, such as persistent infections, autoimmune disease, or chronic irritants. Unlike acute inflammation, which is dominated by neutrophils, chronic inflammation primarily involves macrophages, lymphocytes, and fibroblasts. It is associated with tissue destruction, fibrosis, and angiogenesis, which can contribute to conditions like atherosclerosis, rheumatoid arthritis, and chronic lung disease. Chronic inflammation plays a key role in many diseases. This includes cancer and metabolic disorders. When the body experiences an invasion or injury, it responds with acute inflammation, a natural defense mechanism aimed at eliminating harmful agents and initiating healing. Ideally, this inflammatory process resolves, leading to the termination of the inflammatory process and the restoration of homeostasis and health. However, when resolution is defective or if the injury persists, inflammation continues instead of subsiding. This prolonged inflammatory activity leads to chronic conditions, which can take different forms. Some some individuals develop nonspecific proliferative chronic inflammation, where ongoing immune responses cause widespread tissue damage or fibrosis. Others have condition characterized by formation of granulomas, which is called granulomatous chronic inflammation. And these are clusters of immune cells attempting to contain persistent irritants. If chronic inflammation remains unchecked, it progresses into chronic inflammatory diseases, which can contribute to long-term health complications. This pathway underscores the critical balance between effective resolution and persistent inflammation in determining health outcomes. When the body's inflammatory response persists, it triggers a cascade of immune and cellular events that contribute to chronic inflammation. The process begins with the release of pro-inflammatory cytokines, signaling molecules that sustain the immune response and attract more immune cells to the site of injury or infection. As the inflammation continues, neutrophils, the first responders of the immune system, undergo degranulation and death, releasing their toxic contents to destroy pathogens. However, prolonged neutrophil activity can also cause collateral damage to surrounding tissues. Following neutrophilic activation, lymphocytes, a key component of the adaptive immune system, become activated, further amplifying the inflammatory process. This prolonged immune activation leads to the recruitment of fibroblasts. These are cells responsible for tissue repair and fibrosis. Depending on the nature and extent of tissue damage, the persistent inflammatory response can lead to two forms of chronic inflammation. Nonspecific proliferative chronic inflammation, which is characterized by tissue repair mechanisms that result in scarring and fibrosis. And then granulomatous chronic inflammation, which is a condition where the immune system attempts to isolate persistent irritants by forming granulomas, which are clusters of immune cells. And this ongoing inflammatory cycle, if left unchecked, can contribute to chronic inflammatory diseases, emphasizing the importance of regulating inflammation to prevent long-term tissue damage. The most favorable outcomes of inflammation is healing, with a return of structure and function. Some destroyed tissues are capable of regeneration, a process where damaged tissue is replaced with healthy tissue of the original type. Regeneration occurs within the epithelia of the skin and intestines, as well as in some organs, notably the liver. This restoration is an example of effective resolution of the acute inflammatory process. Regeneration does not always follow inflammation and may not be possible when extensive damage has occurred or at sites where the original tissue is not capable of complete restoration of normal tissue structure. Where resolution is possible, tissue repair occurs. Repair refers to the replacement of destroyed tissue with scar tissue. Scar tissue is composed primarily of collagen, a substance which fills in the lesion and restores tissue integrity and strength, but cannot carry out the physiological functions of the tissue it has replaced, resulting in loss of function. Wound healing is a dynamic biological process that unfolds in four overlapping phases: hemostasis, inflammation, proliferation, and maturation. The journey begins with hemostasis, where the body rapidly responds to injury by constricting blood vessels, activating platelets, and forming a fibrin clot to halt bleeding. Almost immediately, the inflammatory phase follows, as the immune system dispatches white blood cells into the wound site, triggering swelling, redness, and heat, while clearing debris and pathogens. As the wound environment stabilizes, the proliferative phase takes over, marked by the formation of new blood vessels and granulation tissue, as well as the migration of epithelial cells to restore the skin's surface. Finally, the maturation phase, also known as remodeling, strengthens and restructures the newly formed tissues, ensuring its durability. The duration and success of these phases depend on various factors, including the wound severity, location, and the individual's overall health. Wound healing occurs through two primary mechanisms: primary intention and secondary intention. These processes describe how tissues regenerate and repair following injury, with differences based on wound type, tissue loss, and the complexity of healing. Primary intention healing occurs in wounds that have minimal tissue loss and clean, well approximated edges, such as surgical incisions or minor cuts. This type of healing is characterized by rapid closure through epithelialization and minimal scarring. Inflammation is limited, and the wound heals primarily through collagen deposition and fibroblast activity, leading to tissue regeneration with little granulation tissue formation. In contrast, secondary intention healing occurs in wounds with significant tissue loss, such as ulcers, burns, and deep lacerations. These wounds cannot be closed by sutures or direct approximation due to their size and complexity. Instead, they heal through granulation tissue formation, contraction, and epithelialization. The process is prolonged, involving more intensive inflammation, greater fibroblast proliferation, and increased collagen deposition. The result is often more scarring and a higher risk of infection compared to primary intention healing. Both healing mechanisms involve overlapping phases: inflammation, proliferation, and remodeling. But secondary intention healing is more prolonged and results in greater fibrotic tissue formation. Understanding these processes is essential for optimizing wound care and minimizing complications. The dysfunction of wound healing as a complex process is influenced by various intrinsic and extrinsic factors. Wound healing occurs in four overlapping phases: hemostasis, inflammation, proliferation, and remodeling. However, dysfunction may arise due to factors such as ischemia, infection, malnutrition, or chronic diseases like diabetes mellitus. One key dysfunction is impaired inflammation, where either excessive or insufficient inflammatory responses hinder proper healing. Prolonged inflammation can lead to excessive scar formation, such as keloids and hypertrophic scars, while inadequate inflammation may prevent effective tissue repair. Additionally, dysfunctional fibroblast activity and poor collagen deposition can result in weak granulation tissue and delayed wound closure. Infection is another significant cause of wound healing dysfunction. Pathogens can invade the wound, triggering an excessive immune response that damages surrounding tissues and impairs the regenerative process. Chronic wounds, such as pressure ulcers and diabetic foot ulcers, often result from persistent inflammation and poor perfusion. Moreover, ischemia, due to inadequate blood supply, restricts oxygen and nutrient delivery, delaying cellular activities essential for healing. Malnutrition, particularly deficiencies in proteins, vitamins A and C, and zinc, further compromises collagen synthesis and immune responses, contributing to prolonged healing times. Excessive wound contraction is another dysfunction, leading to contractures that impair mobility, especially in burns. Conversely, dehiscence or wound reopening occurs when tensile strength is insufficient due to factors like mechanical stress, obesity, or infection. Overall, wound healing dysfunction results from an interplay of physiological imbalances, environmental factors, and underlying health conditions. Proper management includes addressing risk factors, optimizing nutrition, controlling infection, and supporting adequate inflammatory and fibroblastic responses to promote effective tissue regeneration. When the body's ability to repair itself is compromised, wounds may take longer to close, become infected, or even develop into chronic non-healing ulcers. For individuals with underlying conditions such as diabetes or cardiovascular disease, wound healing can be particularly slow due to poor circulation, which limits the supply of oxygen and nutrients essential for tissue regeneration. Aging also plays a role, as older adults experience a natural decline in cellular function, leading to delayed healing. Likewise, a weakened immune system, whether due to illness or medications, can hinder the body's ability to fight infection, prolonging the inflammatory phase and preventing proper tissue repair. External influences further complicate the process. A wound that is exposed to constant pressure or movement may struggle to close, while infections introduce harmful bacteria that can overwhelm the body's defenses. Certain medications, such as corticosteroids and chemotherapy agents, suppress immune function, making it even harder for the body to heal. Additionally, poor oxygenation, caused by conditions like smoking or peripheral vascular disease, further slows cell regeneration and collagen production, both critical for wound closure. Ultimately, successful wound healing depends on mitigating these risk factors. Proper medical management, good nutrition, careful wound care are essential to ensure the body can complete the repair process effectively. Without these, the risk of complications such as chronic wounds or severe infections increases, making intervention and prevention crucial aspects of wound management.